In Australia, we had a Royal Commission into abuse for elderly Australians, and which came out with a lot of recommendations. We also had a Royal Commission, which is an inquiry, Commonwealth driven on disability as well. So to identify if there is violence, abuse in different settings. One of the things which came out as a recommendation was something called human rights-based practice, and to implement, so to see this person as a whole and to move away from a medical model or a clinical model to, this you have a problem, let's medicate you, to a social or a community model. That's the broad aspirations, to move from a clinical or a medical model of serving to a social model or a community model of serving. So how is that understanding of, are we in the US, are you moving away from that kind of a service delivery?
In Connecticut, we are. That's the aspiration, and the basis, at least in the statutes, is of a human rights-based approach, and an individual centric approach, so that the person has statutory protections, and that the role of care and care providers is to respect their individual autonomy, independence, decision-making as a primary focus. And there is a shift in funding that's happening away from institutional residential settings toward community-based care. But it's challenging, both in terms of, as you mentioned, the workforce and finding adequate people to provide the care, and also on the families that are sandwiched sort of between caring for children, caring for aging parents, and finding some balance when there is a significant level of care for the elder, because the nature of some of the medical challenges, such as dementia, make it an inherently difficult thing to do. So models are bound to be aspirational, but in the details, sometimes messy.